Oh, okay. Welcome, everybody. This is our education, our annual education for the our National Heart Month for February 2026. Today we are lucky to have a provider that lives here in Casper, and he is going to talk to us about the monitoring of the blood pressure and how it helps in his practice and how it helps with the practice on diagnosis. So, with that being said, like Kara said, if you guys would go ahead and put your name and where you're from in the chat so we can kind of keep track. And then also too, this presentation will be out on our WyoLearn platform for you to look at and get the materials for at the end of it. So with that being said, I'm going to go ahead and introduce Jake. This is Jake Elhert. He's a certified family medicine physician assistant at Western Medical Associates in Casper. He received his Bachelor of Science in Ecology and Conservation Biology from University of Idaho. He received his Post-Bachelor Pre-Medical Certificate from Montana State University, and he earned his Master's of Science in Clinical Health Studies through the University of Washington School of Medicine. He is a member of the National Commission of the Certified Physician Assistants. And so I would like, without further ado, I'd like to introduce Jake and we'll go from there. Thanks, Jake.
Awesome. Thanks, Gavin. Appreciate it. Good morning, I guess afternoon now, everybody. I'm in California, at my brother's house, so we do have some dogs in the background, so you'll have to forgive me if the dogs start going crazy here. Blood pressure management is something that when I got into school, I didn't really think a lot about, but in primary care, especially preventative medicine, it's one of the areas where you can have the most good. Blood pressure is something that is undertreated and underdiagnosed. And it's a way that we can really help our patients to live healthier and live longer lives. And it's fairly easy to do. What we'll talk about today is about kind of diagnosis of blood pressure. What we're not going to talk about is medication management or anything like that. This is more of the screening and diagnostics side of things. I'd be happy to answer some questions about management at the end if anybody has that more clinical kind of questions about, medications, et cetera. But really, this is more of kind of what we're doing as far as just the screening goes. So there was a little bit of an update to the AHA blood pressure management guidelines in 2025. We're going to touch on that a little bit today. Really understanding the why of why we care about blood pressure, just looking at those cardiovascular risks. And then really the standard of care should be self blood pressure monitoring or home blood pressure monitoring. I use the two words interchangeably in this presentation, but just understand that self blood pressure monitoring and home blood pressure monitoring are the same thing. And then essentially, we're just going to talk about how we can, from a clinical side or from a public health side, really implement some programs to allow people to really be keeping good track of their blood pressure at home. So next slide, please. All right, so going into the new guidelines, this is just a small change from previous, but essentially what we're looking at is our normal blood pressure for most folks is 120 over 80. Elevated, we're looking at a systolic, 120 to 129 over 80. And just to kind of take a step back, I'm not going to make any assumptions about people's clinical knowledge here, but systolic blood pressure is the larger number, and that's the pressure when the heart is contracting. And then diastolic is the lower number, and that's the pressure when the heart is filling. So when we're looking at that, we're looking at a pumping pressure and a filling pressure, essentially. Um, so, having an elevated diastolic pressure by itself can be a problem. So if you have somebody who's got a diastolic pressure of 94 and their normal, their systolic pressure is 126, like that's a problem because their filling pressure is still high. That's still hypertension, right? So essentially looking at these categories, really we're the stage 2 hypertension are really the ones we really want to be catching because those are the ones that are going to progress to risk a little bit faster. But these are kind of our new guidelines when we're looking at, diagnosis of is this stage 1, is this stage 2 hypertension? So next slide, please. Um, here's the why, and here's the kind of the meat and potatoes of why we're doing this presentation today. It's the number one preventable cause of cardiovascular disease. So it causes all kinds of issues. About half of the US population has high blood pressure. And as blood pressure goes up, our risk for developing cardiovascular disease goes up exponentially. So, every 10 millimeters of pressure increase in our diastolic pressure, risk doubles. Every 20 of systolic, our risk doubles. I was looking at a study in preparation for this presentation that if you have elevated blood pressure in a person under the age of 40, you're 283% more likely to develop cardiovascular disease than someone who has a normal blood pressure below the age of 40. So the takeaway is really want to emphasize, like, especially in our younger people, like younger patients under 40, we need to be thinking about this and screening for this. And the other component of this too is just because somebody has a normal blood pressure in the office does not mean they don't have hypertension. There's different types of hypertension. It's called masked hypertension. Essentially, you can have elevated blood pressure at baseline, and then you come into the office and it's normal. You may be missing, hypertension there. So this is something that even if somebody has normal blood pressure in your office, this is something we should be thinking about screening all of our patients for, no matter what their blood pressure is. So, and then the other thing, any elevation in blood pressure increases risk. So, like we were talking about, or like I was talking about a little bit ago, um, as our pressures go up, our risk really goes up exponentially. But even small increases in blood pressure are associated with increased risk of cardiovascular disease. So, next slide, please. So here's some of the things that hypertension increases our risk for. Heart attack, coronary heart disease, heart failure, stroke, kidney disease, arterial disease, aortic disease, dementia, like vascular dementia, cognitive impairment. And again, just hitting this again, the higher the blood pressure, the greater the risk. Especially, looks like we just bounced. Can we go back to the previous slide? Yeah, I mean, especially things like kidney disease and aortic disease. In my clinical practice, I see a lot of hypertensive kidney disease, a lot of heart disease. Something we'll talk about some like lifestyle things. I didn't really include a slide on it, but we probably will talk about it at some point during this presentation. But um, things like sleep apnea is another one that's really common that causes high blood pressure. And that's kind of a side thing we can talk about screening for, but there's a lot of like pretty serious preventable diseases that, if somebody comes in and they're 60 and they've got kidney disease and, they've got visual changes and heart disease and all that stuff. It's like, if we would have started screening for this at age 30 or 35, we could have prevented all of this disease burden. So again, just really want to hammer home that, blood pressure untreated over the course of decades is going to lead to some serious life-limiting, diagnoses, and we need to be screening for it when people are younger and healthy, or even if they're older and they have these diseases, because it's going to save them, money, and they're going to have a better life. It's going to be less of a public health burden, et cetera. So, next slide. So for confirmed hypertension, so that stage one hypertension, that stage two hypertension, our goal ideally is that 130 over 80, or less than that would be ideally the goal, with the optimal goal being 120 over 80. Now, in your elderly patients, I would really be kind of leery to be shooting for that 120 over 80 goal because the risk of a fall in an elderly person is really high. And when you drive blood pressure too low with medications, we worry about essentially like a orthostatic hypotension is what it's called, but essentially your blood pressure being too low and inducing a fall. So for my really elderly folks, over 75, people that have bad osteoporosis, I'm usually actually shooting for a little higher blood pressure than this. So this is really more for those people that aren't that like very elderly, increased fall risk, et cetera. I really feel like those people are kind of in a whole different bucket because, at that point, the damage has already been done from blood pressure typically, and the primary goal is preventing a fall because if they fracture a hip, there's like a 30 or 35% chance of them, dying from that hip fracture in the next year. So that's really kind of more of the harm reduction on those older folks. But for most people, we're talking that 130 over 80 or less. And for most of my patients, ideally, I want them at 120 over 80 or less. Um, and then again, that shared decision making, individual patient factors. I talked about that a little bit, but for somebody that is, really physically active, for example, and they're noticing that, blood pressure medications are impairing their ability for them to do their job. This is not a one size fits all prescription for people. There has to be some flexibility because certain patient factors, people may not tolerate certain medications. They may have a job that doesn't allow them to take medications in the same way. So just really emphasizing that this is individualized based on the patient and not just a one size fits all prescription. But for 90+% of the patients that I care for, that 120 over 80 is really what we're shooting for. So next slide. Um, so this is kind of going into the main gist of this, but essentially, why do we care about self-monitored blood pressure or home blood pressure monitoring? And the big picture is because it's way more accurate than what we can get in the office, and it also tells us what their blood pressure is doing outside of a clinical setting. So I would say better than 30% of the patients that I see have elevated blood pressure readings in the office, but at home, their blood pressure readings may be normal. I also have patients that have normal blood pressure readings in the office, and at home, they're high. And getting more data points, they come to your clinic, once every month, every 2 months. You're not getting enough data points to really have any sort of statistical value or statistical strength there to really make a decision on whether they need aggressive management or not of their blood pressure. So essentially looking at the data on your sensitivity and specificity for home blood pressure monitoring, it's more sensitive and it's more specific than blood pressure monitoring. So it's just straight up, it's a better number. It's telling us, a better better information, better data for us to make our clinical decisions off of. And the second part of this too is that it helps us identify what their blood pressure is doing when they're not in the office, which is important. If I have a guy that comes in and his blood pressure is 170 systolic in the office, but at home he's 115, if I start him on medication, he's going to be severely hypotensive at home because he doesn't need it, right? So it's going to help prevent those, medication associated injuries potentially. It's also going to find that masked hypertension. So if their blood pressure is, normal in the office, but it's high at home, that's going to pick that up. And it also is going to tell us how our control is. If we don't really know unless we have enough data points if our medications we're using are working properly or not, which is why every single person that has hypertension should be home monitoring, period, full stop. Um, it is going to pick up those daily trends as well. If somebody's really hypertensive in the morning because they have untreated sleep apnea, and then their blood pressure normalizes throughout the day. It's going to pick those little details up too, which is going to really help guide our clinical decision making as far as medication management, as far as further testing. Do they need a sleep study, et cetera? And it's also going to be helpful too, if they notice, oh, I eat this really big salty lunch every day, and then in the afternoon my blood pressure is high. Like it could even help guide, you know, feedback as far as dietary changes, etc. If you notice that just one blood pressure a day is really high, well, what are you doing before then? Oh, you go to the gym and then you come home and take your blood pressure. Well, that's probably what it is. But just getting those data points is going to be really helpful to kind of parse out what the drivers are of those elevated blood pressures, just so you can essentially have a better hold on what your patients are doing. So, and yeah, just the last part of this, home blood pressure, self-monitored blood pressure predicts cardiovascular outcomes better than in office because it's more accurate. So that's pretty much it. Next slide. So essentially, when to use home blood pressure monitoring, I'll save you guys reading the slide. In all cases, we should always be doing this with every patient. Essentially, to confirm the diagnosis of hypertension, we should be home blood pressure monitoring, figuring out if their office readings are accurate or not. If it's masked and they're high at home, we're going to figure that out. If they have white coat hypertension, so they're high in the office, but their blood pressure is normal at home, we're going to find that too. Monitoring blood pressure control during treatment, because one reading in an office is not enough to say, hey, this medication, this patient is on is controlling their blood pressure. Titrating medication, so if I'm going up or down on dosing, that also is going to affect that. I think part of it too is patient buy-in. So if they're actually involved in their medical management, essentially if they're the ones that are monitoring things, you're going to get better compliance as far as them taking their medications and staying on top of things. Also there's quite a bit of data out there that if patients are involved in their medical management, they tend to take things more seriously and actually follow through. So there's actually really good data to support that, by empowering patients, they actually are going to have better outcomes because they're more invested in the outcome. And then again, just that medication adherence or compliance. So essentially, it's recommended for ongoing management in all willing patients. That's the the big thing there. There are some patients you're going to get that are going to say, "Heck no, I don't want to do this. I'm not going to get a blood pressure cuff." And you get a few of those here and there. And for those patients, you're kind of stuck with the data you have in the office. Sometimes you can get them to take meds, sometimes you can't. If you look at the adherence data on patients that we prescribe prescription medications to, I think it's about, I think 30 to 40% based on the studies that I've seen of patients don't take the medications they're prescribed. So it's one of those things that just because you're prescribing medication doesn't mean that your patients are actually taking it. And I would say that like for a lot of the patients that aren't willing to do home blood pressure monitoring, I'd be really questioning if they're actually taking the meds you prescribe anyways. So that's kind of another side thing, but I feel like for most patients though are willing to do this, and I've had a lot of really good buy-in from my patients as far as home blood pressure monitoring. It's really helped me make better management decisions for a lot of these folks. So next slide, please. So we're going to go through just some kind of logistics now of how we talk to our patients about doing this. So how do we want to take a blood pressure? What's the proper way to take a blood pressure? Essentially, the best way we want to do it, we want to have the standardized approach. So every single time, we're having our patients take a blood pressure, we should be doing this. And frankly, like in a clinic setting, we should be doing this too. I will tell you, based on how busy our clinic is, there is no way we can, take a blood pressure, wait 5 minutes, take a blood pressure, um, and then it's just time constraints. We're just in too much of a hurry to get through this. But essentially, the way that we should be doing this, is being seated, legs uncrossed, feet flat on the floor, arm resting, heart surface level. So you want your arm kind of out in front of you like this, usually resting on the table like that. You don't want it like hung down at your side. I can't really show you here. So like this, a lot of times I'll see people kind of go like this. You want it extended like that. So you want it straight. Um, you want a cuff on a bare arm. A thin t-shirt is probably okay, but if they've got like any sort of a heavy shirt on, thick cotton shirt, jacket, anything like that, it's not going to be accurate. The cuff has to be the right size. That's another thing too. If the cuff is the wrong size, it's going to read off. So you gotta measure your arm. Essentially, most of these cuffs have a little mark on them that you can use to actually measure properly, but you have to use the right size cuff. It's going to be a bad reading if you don't use the correct size cuff. So typically they want it to be quiet, so no talking, because if even just talking can change blood pressure, and then should be resting 5 minutes before measuring. Again, in a clinic setting, it's not going to happen. We're not going to be quiet with no talking for 5 minutes. We just don't have the time for that, which is why we want to do this at home, so they actually have the time to do this properly. So, and again, without these techniques being followed, really hard to say whether this is actually good reading or not. And another little tip too, when your patients are coming in to talk about their home blood pressure readings, have them bring their cuff and show you how they do it. And a lot of times that's going to tell you, are they doing this right or not? If you're noticing that their arm's not in the right place, or they bring in their cuff and it's a adult small, but they're a very large person, it's not going to be an accurate reading. So, confirming their equipment is the right size, confirming that they're using it correctly, all of those things is, I think, really important to make sure that the numbers you're getting at home are actually accurate readings. Next slide, please.
Hey, Jake, before you
Yeah.
move to the next slide, we had a question in the chat that
Mhm.
says, what percentage again don't take their blood pressure, even if you've asked?
Um, as far as medications, percentage of patients not taking medications, or percentage of people not home blood pressure monitoring?
I think her question is not home blood pressure monitoring, but Sabrina, if you could come off chat or you could put it again in the chat.
Yeah. So there's
Yes, she
different,
said medications.
yeah. So there's different studies, have different numbers. But like I would say the studies that I've seen, um, as far as medications, like people that are not taking the medications that they're prescribed properly, so either not taking them consistently or not taking them at all, between 30 and 45% of patients, from what I've seen. And there's different studies that are out there. I've seen, I think, as low as 20% on the low end. And I think I've seen as high as like 50 or 60% on the high end. But I think most studies are right in that 30 to 40% range of patients just aren't going to take what you're prescribing them. And there's a lot of barriers to that. Cost is a huge one. So, if they're on diabetic medications that are $500 a month, probably not going to be taking that consistently because they can't afford to. Part of it is people are just busy. I got a lot of oil field workers that I take care of that go on 2 week stints when they're, out in the boonies working 16-hour days. They don't remember to take them because they're just too busy, or they're working nights and they're just not staying on top of it. There's some people that just don't care. There's some people that don't have access to get to the pharmacy. So it's not necessarily like the patient not wanting to take it. It's more of there's just hurdles in the way that keep them from being able to get access to the things they need to get access to. Um, as far as home monitoring, I haven't seen any research on that. I'll have to do a little digging and then answer the percentage of patients that won't do home monitoring. I don't know off the top of my head. So just here's kind of a diagram. This is from the Cleveland Clinic, just kind of showing what proper blood pressure monitoring should be looking like. We should be using typically an automated cuff just because I don't trust patients to, actually feel their pulse right, take it properly. Again, see that arm is extended, so it's at heart level, sitting upright and legs uncrossed, feet on the floor. Next slide. Um, So we need to make sure that the cuffs that our patients are using are validated. Validated means they have been tested by a third party. And essentially we know that the numbers that cuff is spitting out is accurate. Wrist cuffs are the bane of my existence. I hate them. They are really, really, really inaccurate. And half the time you tell patients, go pick up a blood pressure cuff. They go to Walmart or Walgreens, they get a wrist cuff, and it's garbage. We can't use the numbers off of it because they're so inaccurate. If your systolic blood pressure is changing, 30 mmHg every time you take it, that's not a good cuff. It should be reading consistently every single time. So just I really that's if you remember one thing from today, it's take your home blood pressure. If you remember a second thing from today, it's take your wrist cuffs and throw them in the garbage because they're worthless. Get a arm cuff because that's the only thing that's really going to give you good data. Um,
Hey,
you know,
hey, Jake, have you heard anything about all this new Apple stuff, these watches and all this stuff? There's really no way that they can get an accurate pressure, is there?
no, I don't think. I think it's possible you could get an accurate pressure with it, but they're not validated by AHA. So I wouldn't, it's not standard of care. I'll just put it that way. I mean, if you're following standard of care, evidence-based medicine, which is what I strive to practice, you should be using a arm cuff that is validated. Um, so the other, big thing, we talked about this a little bit ago, but just the correct cuff size. You got to make sure the cuff is the right size. If your cuff is too small, it's going to make the pressure off. If the cuff is too big, it's going to make the pressure off. I've seen it shift, systolic of 20 just by switching arm cuff sizes. I mean, it makes a huge difference. You could completely miss a hypertensive patient, or you could have somebody that's really well controlled that looks like they're really hypertensive just because we're using the wrong size cuff. So, if you're in a clinical setting, make sure you got all sorts of different cuff sizes. And usually there's a little mark on there, that you can use. And there's kind of a range where when you wrap it around the arm, it'll tell you if it's in range or not on the cuff. And if it's not, you need to either size up or size down a cuff. And I'm talking about just adults today. With pediatrics, it's even more important though. Like with pediatrics, you got to be using the appropriately sized pediatrics cuff. And it's kind of a pain to have to pack around, 6 or 7 different sized cuffs. But if we're actually wanting to know what an accurate blood pressure is, which is really important for making clinical decisions, if somebody comes in and, they've been sick for a week and their blood pressure is, 100 systolic, versus 80 systolic, that makes a huge difference in my medical decision making. If they're 100 systolic, I'm probably going to give them some fluids and send them home. If they're 80 systolic, they're going to the hospital to be admitted. And, that decision to admit or send somebody home legitimately could come down to what their blood pressure is. And again, we really need to be making sure that the numbers we're getting on our blood pressures are accurate because it can make such a huge difference in medical decision making on the provider side. Um, I think that's it on this slide. If you want to hop to the next. So the AHA's guidelines for home blood pressure monitoring, we should be ideally taking 4 measurements a day. 2 measurements in the morning, 2 measurements at night, and ideally we do that for about a week at a time. And then usually I'll have people take a break so they're not having to do this on a regular basis. And then 1 week a month, I just have them jump back in on and do this. So typically, in the morning, you know, hour or so after you wake up, not after coffee, not after exercise, take a blood pressure reading, wait a minute, take another one, go on throughout your day. In the evening, repeat it, and usually do that for about 7 days. So if you do that for a week, then you get 28 readings, and that's got enough statistical power that you're actually able to come up with some good idea of where the patient's blood pressure is at, and then you can kind of go on from there. As far as ongoing monitoring, there's different ways to do this. For some patients that I see, it's just too onerous to do it on a regular basis. So I usually just tell them first week of every month, I want you to take your blood pressure for a few days, and then we keep track of that. I tend to, I think, get better buy-in. It isn't following the guidelines necessarily. If people are willing to do it every third day, that's beautiful, and I love that. But for a lot of folks, they're just not willing to do that. So I found that, hey, I want you to take it a couple days at the beginning of every month. I tend to get pretty good buy-in with that and people follow through. Have a stack of blood pressure logs in your office or clinical setting. American Heart Association has this great little printable booklet sheet thing. It's just blood pressure log, date, time, systolic, diastolic heart rate, just right there. And I just have a stack of those in my office. And anytime I've got blood pressure conversation going on, which is most patients every day, you just hand them one of those and say, hey, keep a log for this, and or get a little booklet and keep a log and then bring this back. If they don't need to necessarily be seen for like blood pressure management, or they don't need like a provider level visit, but you want to make sure their cuff is right, that they're taking their logs, etc. A lot of times you can set up a nurse visit. I'll do that with some of my patients where I have them come in. They essentially confirm that they're taking their blood pressure properly. We get essentially a review of their log, and then I can just glance at that and then make a decision based on that. Is this something where I need to adjust medication up or down? Do I need to initiate medication? Do we need to discontinue medication? Um, is this type of thing where they're on multiple medications and we haven't gotten optimal control, so we need to refer to a cardiologist now? It just is really helpful for making those management decisions. So, next slide. Another takeaway, which is something that I actually learned doing this presentation, is that home blood pressure readings are not necessarily correlated with office readings. So just because of differences in cuffs, interpretation, etc., we assume that their home blood pressure readings are lower than what their true office readings are. So we always tend to be a little conservative, which, like I said, until I made this presentation, I didn't know this. So this might be new for a lot of you folks too. I was not taught this in school. Um, but anyways, for like 130 and under, we assume that the home blood pressure readings correspond with the office blood pressure readings. When we start getting into hypertension, essentially you're adding, that 135 over 85, we're correlating that with 140 over 90 in the office. And I didn't put it on the slide because I didn't have space, but if you go higher, that 155 um, over, I think, 95 correlates with a 160 over 100. So, essentially just take that home reading, anything that's hypertensive, just add 5 to both the numbers, and then that's really what you should be managing based off of, which, again, that was news to me, and this changed my clinical practice. It's one of the great things about medicine. It's called the practice of medicine. You're never going to have everything quite right. And, um, I think just being nimble and learning things is great. But yeah, like when I made this presentation 2 weeks ago, like I've been changing how I've been interpreting home blood pressure logs since then. So it's been really helpful for me. And hopefully be helpful for you in your clinical practice as well. Um, Essentially, anything over 130, I mean, that's stage one hypertension, but um, essentially that definition or the diagnostic for do they have a diagnosis of stage one hypertension would be that home blood pressure average of 130 over 80 or more. So next slide. So this is going to be the part that's going to fall pretty heavily on providers, medical assistants, public health, et cetera. This is the how do we get people to actually do this? We know it works. We know the data we get from it is good. We know that it's going to be the best tools that we have to guide our medical decision making as far as blood pressure management goes. But how do we support people? How do we get them to actually do it? So we got to get buy-in, and I think buy-in starts with that education. If the patients understand the why of why they're doing it, I always start with conversations with things about blood pressure because you have patients come in and they talk about blood pressure. Oh, well, my blood pressure is high. What's the big deal there? I always start with the reason I care about your blood pressure is your heart is a pump, and if your pump is working against high pressure, it's going to wear out prematurely. So I want to protect your heart. Your blood vessels are like garden hoses, but if you hook up a garden hose to a fire engine, it's going to start getting balloons. Those are called aneurysms. That's a problem. The third one is your kidneys. They're a filter. They're designed for low pressure, but if we're blasting, water through there at high pressure, we're going to start poking holes in the filters and the screens, and you're going to develop kidney disease. These happen over decades, not years, but that's the reason that we need to address this is because we want to prevent these chronic diseases from happening down the road. I think if patients understand the why, that's really helpful, and it gets them to buy in. And if they understand the why of I don't trust the blood pressure you get in the office. I always joke like my blood pressure is high when I'm in the office too. But it's we want to check it at home when you're relaxed and see where it actually is. Um, Essentially, doing that sort of thing is really helpful because if they understand what's going on, they understand why they're doing it, they're more likely to follow through. Um, Making sure they have a validated device that's the right cuff size. Again, that follow-up nurse or medical assistant visit, I think is really important. If I make a blood pressure, a hypertension diagnosis, I almost always want them to have a follow-up nurse visit to bring in their cuff, to go through the log, to make sure they're using it properly, to make sure the cuff is the right size, etc. I think that's really important just to make sure that they're actually getting good data. Because if they bring in their logbook, but you don't know that they're good numbers, that the device they're using is correct, that it's the right size cuff, the data is useless. You need to know that you're actually getting good data. So I think that follow-up nurse visit, public health, home health visit. I'm not sure, what organizations you all work for, what your clinical practices look like, but I think that follow-up is really important to make sure you're actually getting good data with these numbers. Reviewing blood pressure logs, that should be done at every visit. Anybody with high blood pressure, I usually do it as part of the wellness visits every year if they've been stable on blood pressure medicine for 5 years and they haven't had a change. I think just reviewing it once a year is probably appropriate. If you're in any sort of, up or down titration, I typically want to see them every 6 weeks to make those follow-ups. And everybody's different. I've got some providers that I work with that do 3 months. I got some providers that do 3, 4 weeks. It's just kind of personal preference. Um, Communication, medicine's a team sport. So, essentially, if you're like home health and you notice your patient that you're taking care of has got really high blood pressure, getting that information to their primary care team so they can make decisions on that. If you're provider, medical assistant type stuff, making sure that there's good communication between the teams. So, if somebody brings in a blood pressure log and their numbers are high, like I would like to know about that as a provider. If I am looking for the patient to have that follow-up, I need to make sure I'm communicating that to my medical assistant. Um, my medical assistant's on the call, actually. She's wonderful. So, uh, yeah, and then just essentially reinforcing the patients that home blood pressure monitoring is really it's standard of care. It improves outcomes. It's just we should be doing it with everybody. So, next slide. We've talked about this already. Essentially, the evidence that's here, but essentially, we should be doing this with everybody, and the data is irrefutable that it improves outcomes. Um, I think we've already talked about everything on here. This is kind of getting to your Apple Watch question, Kevin. But we don't do this as a clinic. We don't have the capability to do it yet, but some of the larger like academic organizations are starting to use these kind of things. And I think from a public health perspective, it'd be really interesting to look at rolling out some systems like this, but essentially like remote monitoring of blood pressure. So you have a validated device, you know it's the right size, you set it up with the patient, but then instead of them having to take a log, essentially it connects via the internet and keeps a log for them. And then as clinicians, you know, you get access to that data, and then you can get essentially real-time feedback on how your management decisions are working. I think this is the future of medicine for sure. I think in Wyoming, we're probably a decade at least before having this capability. I mean, there might be some organizations in the state that do. Our organization definitely, our EMRs, there's no way our EMR could ever work something like this. But you know, essentially remote monitoring is helpful. You know, smartphone apps are really helpful. I actually do use smartphone apps a lot for my patients, one for the reminder, but also it's like a digital log so that if they don't want to keep a paper copy, they can just log everything on their phone. There are some blood pressure devices that will link up to an app on their phone. So when they take their blood pressure, it'll actually populate in their phone. So there's definitely some tools there. You know, since COVID, we do a lot more telehealth now because insurance is actually reimbursing it. So there are patients, you know, I've got patients that I see, even though I'm based in Casper, I've got patients that come from Riverton, Gillette, um, all over the place that I do for primary care. And a lot of those people I will do over telehealth to save them a 2+ hour drive. So it's the type of thing that we can do a lot of this stuff over telehealth, even the education piece of it, you know, making sure that they're you know, taking their blood pressure right. You know, you can do that over a phone call, or, you know, most people have one of these things now. And, you know, there's a lot of awesome tools out there. You know, Doximity's got a free HIPAA compliant video conferencing tool on there. So I'll pull up Doximity and essentially it's just like FaceTime. You FaceTime with the patient and they demonstrate how they're doing stuff and you can see it over the phone or over the video and then actually give them that real-time feedback. And I think that's a really important tool for Wyoming just because the geographic distances are high. Or if you got that old person that's really, you know, homebound, has transportation difficulties, like that's really, really helpful too, just to save them the trip out of the office, you know, especially if we had like a bad snow day like we did last week. Like it's a really, really helpful tool. So, and then just improve access. Again, just those under-resourced, underserved organization or populations, I think, you know, that telehealth is going to be really important there. Um, and yeah, it's technology in and of itself isn't that helpful, but when we have a lot of support, you know, that good education, that good follow through on the provider side, I think that's really where it makes a huge difference. So, next slide. These are like kind of these common mistakes, home blood pressure type stuff. We've talked about most of these things already, but I just wanted to kind of hit them again just because it's really important. So, if your patient brings in a blood pressure log, don't just eyeball it. We should be actually calculating an average. And yes, it takes some time, but you know, it does not take that much time to pull up a weighted calculator average on your phone and plug in numbers and get an answer. It takes a minute tops, you know, rather than just saying, oh, you know, some of these are 140, some of these are 130. Like if we're following standard of care, we should be calculating an average on these people. Um, as far as patient coaching, don't measure blood pressure right after you wake up. Don't take it right after you eat. Don't take it after you exercise. Don't take it after you just had 5 cigarettes, which is pretty relevant in Wyoming, I feel like. Um, don't talk during the measurement. Don't measure through clothing. I would say thick clothing is the big one here. Again, if you're wearing like a super thin athletic shirt like this, it's probably not going to make a huge difference. But if somebody's got on any sort of like heavy clothing or really bulky clothing, that's going to be the issue. And ideally with a t-shirt, you just pull it up and then you actually do have good skin to skin contact. But I would just say like anecdotally from what I've seen in my practice, that's kind of what I would say. Um, don't use the arm unsupported or at the wrong height. Again, that arm needs to be extended in front of you at the like at heart level, essentially, where that measurement is being taken place. If you're doing that initial reading, that first 7 days, you know, it needs to be consistent, especially if we're going up or down on medication. I don't want to have gaps because I want to see the trend of blood pressure associated with the medication change. Typically, we're not going to be wanting to, you know, start a medication and then they take blood pressure for a few days before the medication's really taken place. Then they take blood pressure after, and it's all over the place or variable. That's not really that helpful of information. It's really good to have that kind of consistent follow through data through that whole period. I really feel like it's most important to do that when you're doing the medication up or down titrating. Um, and then the other one, which for your patients that have a little more medical anxiety, just one reading that's high doesn't mean anything. I have people that come in all the time. I have this one reading of 160, and I'm so worried that my blood pressure is out of control. Well, you just ate and you went for a walk and you had a hard time at the DMV that morning, and your blood pressure is high. Big deal. We're looking at averages here because this is not a type of thing where one single reading is going to cause harm. It's the average being elevated over a long period of time. So that one single reading, or like 4 days a month, they're severely hypertensive, but the rest of the time they're normal. Don't worry about it. It's the average that matters. It's not that single reading. So, next slide. So it's just some barriers to home blood pressure monitoring. I think this is kind of more on the public health side of things, but everybody that works in medicine kind of does some public health because our patients' resources, we have to work within the confines of that. Cost of devices. So essentially community programs. Wyoming has a fantastic program. It's the library program. I use it a lot. Essentially, there's blood pressure cuffs that are validated in all the libraries in the state of Wyoming, is my understanding. You'll have to correct me if I'm wrong on that, Kevin and Kara, but it's a great tool for my patients that don't have a lot of resources. Say just go to the library, check out a cuff for a week, take it home, do your 4 logs a day for a week, take it back to the library. And it works fantastic because it's got instructions, it's got all the information they need to do it right, and I know the cuff's validated. So that is actually one of the times where if they are taking their if they're following the instructions, which is a big if, that's one of the few times that I actually feel like I don't necessarily need to have them come in for that follow-up visit to make sure that their cuff and everything is right because I know it's validated and I know that there's good instructions with it if they're following the instructions the way they're supposed to. That's a big if there. Um, Essentially, confusion about technique would be the next one. So hands-on training. So essentially demonstrating what proper blood pressure monitoring looks like in the office setting. So taking the time to, when I'm taking your blood pressure, this is the position I want you in. This is where I want your arm. This is where the cuff needs to go. This is how I measure the cuff to make sure it's the right size for you. All of those things are helpful so the patients are there. As far as forgetting to measure, I usually just have folks just make it a part of their day. So I tell folks, before you eat breakfast in the morning, an hour after you wake up, but before you eat breakfast, I want you to take your blood pressure twice. And then before you eat dinner, I want you to do the same thing. And then, so that association with meals has been pretty effective in my practice. I think with phone alarms. I think that works great. Just something to do so they're reminded to do that. And your old, retirees, it's not gonna be a problem. They get all the time in the world. It's usually the younger, like more busy folks with families that this is a little bit more of a challenge with. Or your guys that are doing shift work where they're working nights than days, then nights than days. That can be pretty challenging in those cases. And there has to be some flexibility there with those kind of folks, especially the shift work when their sleep cycles are going back and forth. Like I feel like just that in and of itself already kind of jacks the blood pressure quite a bit. So with those folks, you may have to get a little creative. As far as the anxiety about readings, kind of talked about this on the last slide, but that one high reading, I tell people don't look at it. And again, I really reassure people like the blood pressure itself in the short term doesn't matter unless it's, crazy high. But like in the long term is really what we're caring about. This is a long-term, decades-long preventative disease. This is not something that we're worried about over the course of, 1 or 2 years. This is something that's going to take a long time to develop into chronic disease, typically. There's obviously exceptions to that, but just really trying to reassure people this is something we're doing now to make sure you're protected 20 years from now. I think that tends to bring the anxiety down quite a bit. Um, the last one, language barriers. I do have some Spanish speaking people. I do have some deaf patients that I take care of. Essentially visual aids like that Cleveland Clinic printout, like just having some tools like that where there's some sort of visual printout you can give them, essentially explaining stuff. Translation services really helpful. I think those are all good tools. So next slide. So your impact, what can we do? Kind of the takeaway from this. Essentially, today you've learned about why we care about blood pressure, what the data is behind home monitoring, why we care about home monitoring, what targets we're shooting for as far as blood pressure control goes. Um, Essentially, right now, blood pressure hypertension is massively underdiagnosed and massively undertreated. And a big part of the reason for that is we don't screen for it effectively. That's the main reason. And if we were taking home blood pressures on 90% of the population, we would catch a lot more of it and we would treat a lot more of it, and the disease burden on society would be a lot less. Um, there are significant disparities based on age and race. A lot of young people aren't checking their blood pressure. Really, is a lot of younger folks or older folks that don't have, resources, financial means. There's a lot of seniors that are really struggling. Race disparities and blood pressure management, social determinants of health. There's a lot of really different population groups that are very under-resourced as far as access to medical care, as far as financially resourced, et cetera. That's been pretty well established that a lot of different populations really struggle with health outcomes because of that. And I think just improving investment in those communities, I think would be really helpful. What you can do, essentially teach accurate measuring technique, encourage people to actually take their blood pressure at home, support medication adherence. So if they have problems getting their meds, can we do mail order? Can we get them to the pharmacy? Can we get them, to a community health pharmacy so they can get discounted medications? Um, all of those things, explaining to them why, so they actually have buy-in and actually want to follow through with this. Communicating concerns to providers. So, you're doing a home health visit, you see that your patient's blood pressure is 155 systolic and it's been there every single time for the last 2 months, get a hold of their primary care clinician and let them know. Like that's something that good communication, that team sport kind of mentality in medicine can really be helpful. And then just generally just empowering patients and self-management. So next slide. Um, so just kind of more key takeaways. 2025 goal, anything 130 over 80 or less, and encouragement really towards that 120 over 80. Home blood pressure monitoring, more accurate. The novice blood pressure predicts outcomes better. Proper technique. If you don't have it, those numbers are worthless. So you got to make sure that patients are using the right cuff, the right size, the right positioning, and they're doing things lifestyle wise before their blood pressure management that is not throwing or their blood pressure monitoring that's not throwing it off. The schedule, again, 2 readings in the morning, 2 readings in the evening for a week is required for diagnosis. So that's the diagnostic criteria is that 28 readings with an average over 130 over 80. And your support, education for patients is what's going to make the difference and ultimately is what's going to improve outcomes. So next slide. Here's some resources for you. There's a blood pressure validated device listing. It's on the American Heart Association website. It's validatebp.org. If you have a pen handy, I would write that down. That's the site that I use. The Stride BP website works pretty well too, but the one I use the most is the Validate BP website, and it's got a whole list of validated blood pressure cuffs. So when patients are like, I don't know what cuff to get, I always tell them, go to Validate BP, find a cuff, and there's different price ranges of cuffs in there based on the features they have. So there's quite a bit of variability as far as costs go. And I always tell folks to order it, online. Sure, you can get validated cuffs at Walgreens or Walmart, but almost always they're marked up exorbitantly high. Um, Walgreens in particular, I feel like just does a really bad job of just really overpricing stuff. Walmart's not quite as bad, but I always just tell people to get it online because I'm trying to be as cost conscious as possible for my patients. For patient education, American Heart Association, heart.org, um, the Medical Association framework. There's a whole bunch of different websites out there that talk about blood pressure management. There's all sorts of forums, resources, etc. Get on the internet, find a good, academic medical center. They should have a whole bunch of resources you can use, and any of those things are going to be good. So I think that's it for the presentation. Any questions?
Well, I'm not seeing any in the chat yet, but I will say, I think your explanation of the heart being a pump and those things really resonated with me. And maybe it's because we worked on the race car this weekend. But that was definitely good. And I think really for our patient population in Wyoming. So one of the questions was, will this be sent to us? Yes, we will send handouts of these slides to everybody that registered for today's presentation. So we'll send those out via email later on today. Along with a recording of this will be on our WyoLearn website.
Okay, well, if you guys have any questions, keep them coming, put them in the chat, or just take yourself off mute. But a little bit of information here. I know Jake had had said something about our blood pressure kit program. Yes, we do have it. It is in all 67 libraries in the state of Wyoming. And it's been going on for almost 3 years now. And we average anywhere from 50 to 60 blood pressure kits a month that are checked out statewide. So it is, and I really appreciate, where Jake puts in that awareness is one of the huge, interventions of letting people aware. So keep in mind that our blood pressure kits are available. Also, through the state program, there's a Healthy Heart Ambassador blood pressure self-monitoring program. This is a 4-month CDC approved program, and there are some opportunities with our state Wyoming State Health Department. So I will put that information will be on the slides where to get that. And then the self-measured monitor with clinical support. What is SMBP? This kind of goes a lot with what Jake was talking about. But if you are in a practice, there are, a part of the care coordination and part of the Medicare looking at how we're going to take care of our elderly population. This is a reimbursable, program from Medicare. There are some third-party payers that are getting on board with this. So eventually, like Jake said, this is the future. I mean, a lot of things are coming up that we can do at home. The telehealth information from the budget from the Congress, that all the telehealth rules, have been in place until the end of the year. So again, we're moving forward in that aspect. So to keep you in control of that. And one of the last things I want to talk about is the Healthy You programs, on the workshops and everything that we have through the WYCOA. This is a program that is peer-led, but we have a number of workshops around the state, a number of trained facilitators, and this is more of a healthy, lifestyle program. And so again, this touches on that and so forth, but again, getting people to be aware of their health. So this is the contact information. And again, you'll get all this information when we send it to you. And I think with that, is there any more questions?
I am not seeing any more questions in the chat, but it looks like you have a lot of thank yous and excellent presentations coming your way, Jake. That was a great presentation today. So thank you so much for your time.
So do we have a poll? Did you?
We will. So
Okay.
thank you all for being here today. As soon as you leave today's presentation, you're going to have a pop-up on your screen of a little bit of a survey that we'd like you to complete. So please do that before you leave your desk today, and we'll see you later. Thank you guys so much.
Hey, Jake, do you want to stay on for just a minute?
Yeah.
Okay, sounds good.